Good afternoon, everyone. My name is Eleni Anselatis. I am from the Community Health and Wellness Department at Suburban Hospital. Thank you all for being here today. Today, we have Dr. Camille Stanback from Sibley Memorial Hospital, and she will be presenting the connection between diabetes, type 2 diabetes, and obesity in honor of Diabetes Awareness Month, which is in November. Before we begin, I wanted to just go over a few housekeeping items. First of all, today's presentation is being recorded and will be made available within the coming days. Secondly, if you do have a question, please use the Q&A box at the bottom of the screen to ask any questions that you may have, and we will answer them at the end of Dr. Stanback's presentation. And finally, the evaluation. We love to hear your feedback, suggestions for future topics. And at the end of the presentation, at the end of the webinar rather, a link will be sent out. And I encourage everyone to please take the time and complete that evaluation. Today we have, again, Dr. Camille Stanback from Sibley Memorial Hospital. She is an endocrinologist and specializes in diabetes and obesity. So thank you again, Dr. Stanback, for being here this afternoon, and we will get started.
Great. Thank you for having me. So as Eleni mentioned today, in honor of Diabetes Awareness Month for the month of November, I will review type 2 diabetes mellitus and obesity with an emphasis on prevention and treatment. To outline today's talk, I will start with definitions and terminology, then review the social impact as well as economic impact of both diabetes and obesity. We will then delve further into the causes and risk factors for type 2 diabetes and obesity and conclude with counseling and treatment options. So first, to definitions. There are actually three ways of diagnosing diabetes. The fasting plasma glucose or blood sugar level is typically drawn on routine blood work, either in a basic or comprehensive metabolic panel. And by fasting, this is at least 8 hours without food or beverages other than water. The oral glucose tolerance test is less commonly performed with the exception of pregnancy. It involves measuring the plasma glucose or blood sugar level 2 hours after an oral sugar load. And the third test is the hemoglobin A1C. This is one of the common screening tools that we use in practice to screen for diabetes. It's a blood test, and it provides a correlation of an average blood sugar over the preceding 3 months. Thus, it gives an indication of blood sugar control over a longer period of time, as opposed to a point in time as the other tests do. It's important to note that one test is not sufficient for the diagnosis of diabetes. The diagnosis must be confirmed either on a subsequent day, repeating the same test, or on the same day using a different test with concordant results. The exception to this is if there are signs or overt symptoms of high blood sugar, confirmatory testing is not needed. While the purpose of this slide is to define and diagnose diabetes, I do want to highlight prediabetes. As its name suggests, it can precede diabetes, and it's a risk factor for developing type 2 diabetes mellitus. This is an important target for prevention and ultimately preventing and treating progression to diabetes. So what are some of the symptoms of high blood sugar? While they can be asymptomatic, many individuals do have subtle symptoms that we subsequently realize were related to hyperglycemia. They can include blurred vision, increased thirst, increased urinary frequency, and unintentional weight loss. Then what are the risk factors for developing type 2 diabetes? While this is not a comprehensive list, it does include some common risks that we see in practice. The focus of this discussion will be on overweight and obesity, as well as increased waist circumference. Further, a sedentary lifestyle, as well as high blood pressure and high cholesterol serve as risk factors for the development of type 2 diabetes. Other non-modifiable risk factors, which we cannot control, include a family history of diabetes, a history of gestational diabetes or diabetes during pregnancy, as well as age greater than 45. So why is there such a focus on diabetes? Why is there a whole month dedicated to awareness? The answer is that it affects a lot of people. As of 2019, over 37 million people in the US had diabetes. That's over 10%. And that includes both those diagnosed and not diagnosed, with over 1 million new cases diagnosed every year. This all boils down to over $300 billion in costs. And that's both direct medical cost as well as reduced productivity. Now, how do we define obesity? Well, first, it's important to recognize that obesity was not actually recognized as a disease by many organizations until 2013, when the American Medical Association classified obesity as a disease. And this was amid some controversy. Now it's recognized by the World Health Organization, as well as the Centers for Medicaid and Medicare. And this has had implications for how we treat obesity, including both obesity medications, surgery, as well as counseling. The first step in assessing for obesity is measuring the BMI or body mass index. This is a simple calculation based on one's weight in kilograms divided by height in meters squared. It does have some limitations. For example, those who are extremely muscular may have a falsely elevated BMI, whereas in the setting of muscle wasting, the BMI can be underestimated. In that case, we also use the waist circumference, which measures abdominal obesity and indicates increased cardiometabolic risk. These risks include heart disease, diabetes, high blood pressure or hypertension, high cholesterol, non-alcoholic fatty liver disease, as well as overall mortality rates. The classification of overweight and obesity is largely based on the BMI, whereas overweight is diagnosed with a BMI of greater than 25, and then obesity classification starts with a BMI of 30 or more, and then is further classified based on the severity of the obesity. Waist circumference has different definitions for men and for women. For men, greater than 40 inches, and for women greater than 35 is associated with increased comorbidities. As I stated previously, the BMI is not perfect. In fact, there are current proposals to adjust BMI for ethnicity. Currently, there are different criteria for Asian populations for both the overweight and obesity categories. Similar to diabetes, obesity affects a large portion of the population. The CDC reported that in 2017 to 2018, over 40% prevalence of obesity. And in 2008, this cost the US over $100 billion a year. Further, over 4 million people die per year from obesity-related conditions, including coronary artery disease, diabetes, strokes, and certain cancers. It's important to note that these numbers are increasing. In fact, this number has nearly tripled since 1975. This predictive model indicates that the prevalence of obesity may increase to almost 50% by the year 2030. And you can see that these numbers have been rising since the 1990s. It is important to note that these may even be underestimated, as this model was done prior to the COVID-19 pandemic. Pandemic weight gain is probably not a new entity now in 2022. But in 2021, an American Psychological Association study found that over 40% of US adults reported undesired weight gain since the start of the pandemic, with an average weight gain of almost 30 pounds. A small portion gained more than 50 pounds. Rates per month showed approximately 1.5 pounds every month using data from Fitbit and iHealth. We've also learned that obesity has become a risk factor for more severe COVID-19 infections. But obesity affects many systems. Type 2 diabetes, mellitus, as we are discussing today, but also high blood pressure, high cholesterol, polycystic ovarian syndrome, as well as certain cancers, including breast cancer, colon cancer, and uterine cancer, to name a few. So what causes type 2 diabetes? The answer is not so simple. There are many factors, including decreased insulin production from the pancreas, as well as increased blood sugar production from other organs. Further, there is decreased ability of the muscles to efficiently use the glucose or blood sugar. And then this is furthered by environmental and genetic factors. Similarly, there's not just one cause of obesity. Our environment, as well as genetic factors, play an important role. Further, stress and mood are important factors, as well as other medical conditions. This goes into, why are we hungry? Well, there are several hormones that are responsible for increased hunger as well as satiety or fullness. And this balance is what we target in looking at why we gain weight. These hormones are also important targets for medications, which we will discuss further. And then why do we eat? Well, there are many signals that we respond to. Hunger is not the only one. There are social factors, celebrations, family gatherings, at work, parties, especially before the pandemic, mood-related triggers for hunger, as well as just the taste, sight, and smell, or our senses. And then the lack of recognizing satiety or fullness, as well as cravings. Overall, obesity typically develops due to an imbalance between energy intake and output. A lot of people have the perception that if we eat something, we can exercise or burn it off, but it's harder than you think. Let's go through an exercise or example. Walking at a rate of 3 miles per hour burns about 5 kilocalories per minute. So if we say 100 kilocalories is 1 mile, we'll keep that in mind. Then let's look at fast food. This is just using the available data from the Burger King website. A Whopper is 669 kilocalories. Using our calculation from above, it would take 139 minutes of walking in order to account for this calorie load, or approximately 7 miles. This doesn't include the fries or the soda that comes with it. This is all part of that imbalance in energy. So in our environment, there's a general overabundance of palatable and calorie-dense food. Thus, the number of calories we expend is insufficient to offset our consumption. We are also increasingly sedentary. We sit at work, we sit in traffic, we sit in front of a computer, especially if working from home. And poor sleep habits are also a contributing factor. This is further on the sedentary life habits. To further review sleep, poor sleep quality is actually associated with an increased intake of added sugars and total weight of food consumed. This isn't difficult to comprehend. When we're sleep deprived, we're less likely to make healthy choices when it comes to eating and be less discerning in our options. There's also an established relationship between obstructive sleep apnea as well as metabolic parameters, including high blood pressure or hypertension, type 2 diabetes, dyslipidemia or high cholesterol, and cardiovascular disease. Now that we've reviewed the importance of recognizing obesity and diabetes and their key complications, now I will review the benefits of weight loss. I'll start by reviewing the concept of incremental weight loss because it's so important. With only minimal weight loss of about 3%, we can already start to see improvements in glycemic parameters such as blood sugars, as well as a decreased risk of type 2 diabetes and prediabetes. With greater weight loss, we of course see greater improvements in health. What I would like to highlight, though, is that we don't need to lose 50 pounds in order to see a positive impact on our health. A weight loss of just 5 to 10% can actually improve blood pressures, blood sugars, and cholesterol. Losing 7% of the body weight can actually reduce the risk of developing type 2 diabetes. Now on to counseling and intervention. So the treatment of overweight and obesity and type 2 diabetes has been reviewed multiple times, and there are guidelines available from the American Diabetes Association, which are highlighted here. In the BMI category of overweight, 25 to 26.9, diet, physical activity, and behavioral counseling is recommended. In some of the higher BMI categories, still in the overweight subset, pharmacotherapy can be added if there's a concurrent diagnosis of type 2 diabetes. And then with a BMI in the obesity category or greater than 30, metabolic surgery can also be considered. So what is lifestyle therapy? Well, as its name suggests, it focuses on dietary changes, physical activity, as well as behavioral strategies. Overall, we want to achieve a calorie deficit in order to adjust for this balance of energy input and output. This is the cornerstone of how we treat both obesity and diabetes. We'll then look at moderate intensity physical activity of at least 150 minutes a week, with an ultimate goal to lose 1 to 2 pounds a week. This is all part of an intense lifestyle modification program with frequent visits aimed at preventing the development of diabetes in individuals with overweight and obesity. And these modifications also help with the long-term success in maintaining weight loss. So physical activity, to look further into this, the type and duration of a physical activity can be correlated with the amount of expected weight loss. We, as I stated, aim for at least 150 minutes a week, as this is associated with some weight loss, about 2 to 3 kilograms. However, with more physical activity of a longer duration, and we're more frequent, we're looking at more weight loss as well as weight maintenance after weight loss. The type of physical activity is also important, as well as adding those dietary changes, including calorie restriction. So which dietary intervention is the most effective? The answer is there's not one that's better than the other. A study from the American Heart Association and Obesity Society reviewed many dietary patterns and actually found that none were superior in the ability to produce and sustain weight loss. So that means low fat, low protein, low carb, keto, Atkins. None has been proven to be more beneficial than another in terms of producing and sustaining weight loss. It's actually the negative energy balance that is the key, so calorie reduction. So in general, the best dietary intervention is the one to which the person adheres, because we want to think of this as a lifestyle as opposed to a diet. The order of macronutrients does have some import. Protein earlier in the day can help with satiety and suppression of the appetite. So it's important to start the day with a healthy source of protein, such as a protein shake, non-sugar added Greek yogurt, low fat or no fat cottage cheese. Fruit is a culprit for blood sugar or elevation in blood sugars. So if one prefers to use fruit, berries have the lower glycemic index. And then egg whites are another good source of protein. So what is this negative energy balance? Essentially, we look at what pounds are in terms of calories. So 1 pound is about 3,500 kilocalories. So simple math tells us in order to lose 1 pound a week, we would need to reduce calorie intake by 500 to 700 kilocalories per day. A quick estimate is that for a female patient under 250 pounds, this would amount to 1,200 to 1,500 kilocalories per day. And for a male patient over 250 pounds, 1,500 to 1,800 kilocalories per day. This is all dependent on other medical conditions and what is safe. So before embarking on a diet plan, I always advise people to discuss everything with their doctor. General principles for long-term success include a few key guidelines. One is to avoid processed food and limit eating out approximately to once a week, as there are other additives and items that we just cannot control. Regular physical activity, as mentioned before, for that maintenance of weight loss, we want to at least look at 200 to 300 minutes a week. Discontinuation of all sweetened beverages, as they are an important source of calories as well as added sugar. Self-monitoring. This can include frequent weighing at home in order to maintain accountability, such as weighing oneself once a week. That way, weight gain can be processed in small increments in order to make adjustments. Food logging is another way of self-monitoring, either through pen and paper or using an app in order to maintain that accountability, as we often tend to underestimate our caloric intake when just recalling based on memory. Limiting screen time also limits sedentary behavior, so limiting to less than 2 hours per day if possible. Even if at work, having a moving treadmill is one way of limiting that sedentary behavior. And then contact frequently with a weight loss program in order to maintain that accountability. Even when doing all the right things, losing weight in itself is hard, and it's even more difficult to maintain. There are many other factors at play. There are a multitude of hormones and nutrients all involved in the regulation in the body, and many of these hormones are perturbed after weight loss. These hormonal changes can lead to increased hunger and desire to eat, and can be accompanied by a slowing of the metabolic rate or metabolism. That's where pharmacology comes into play. So certainly the lifestyle and behavioral modifications are important, but sometimes it's just not enough. When we're thinking about obesity as a disease, it makes sense to implement medication management. as it tends to dampen sensations such as appetite, hunger, cravings, and target the body's mechanisms that resist weight loss. The goal is to help individuals adhere to these lifestyle modifications, and we see greater weight loss with pharmacologic therapy, as well as an increased likelihood of losing more significant amounts of weight, as well as maintaining that weight loss. There are several FDA-approved medications for obesity, and the indications are being diagnosed with obesity, as well as some people diagnosed with overweight if they have other conditions such as type 2 diabetes, high blood pressure, or high cholesterol. The FDA-approved medications include orlistat, phentermine and topiramate, naltrexone, bupropion, liraglutide, and semaglutide. The field of obesity medicine is exciting as new medications are being added to the market often. There are additional off-label medications, which I will not review here, as well as some that are currently in the pipeline. I do want to note that there's no clear evidence that supplements, minerals, or vitamins that are effective for weight management. These include high doses of vitamins and minerals, amino acids, enzymes, and antioxidants, to name a few. This is just another review of the current medications that we have available that are FDA approved for weight management. There are, of course, certain contraindications or reasons that the medication may not be safe for certain individuals. And as with all medications, there are potential adverse effects that need to be monitored. The newest medication that we have with the most weight loss seen is called semaglutide, or the brand name is Wegovy, which can be associated with a mean weight loss of approximately 16 kilograms. It is important to note that some of these medications have a dual purpose of treating type 2 diabetes. We'll review some of those medications further, but namely those include the liraglutide and semaglutide. These are part of a class of medications known as glucagon-like peptide receptor agonists. So what happens if we only treat obesity for the short term or only use medications for the short term? I often get the question, so great, my patient lost weight or I lost weight, can I stop the medication? The answer is when we do that, the weight gain recurs. So if we think of this as treating another chronic medical condition, such as high blood pressure or hypertension, we can have a better understanding. When the blood pressure improves, for instance, we don't stop the medication because it's maintaining our blood pressure. The same goes for obesity. We don't stop the medication once we found success. We continue it because it is continuing to work for us. These are some of the current treatments available for type 2 diabetes. As I mentioned, there are some that overlap with the treatment for weight management. Thus, there are some medications that can be used for a dual purpose and are ideal for individuals with both conditions. In general, I recommend using medications that do have at least neutral or some weight loss benefits. Those medications I've highlighted in green. Of course, as mentioned previously, there are contraindications or reasons that some medications may not be safe for certain individuals. Thus, I always recommend discussing any medications with your doctor, as individualized care is key. Metabolic surgery, as previously discussed, is another treatment for obesity as well as diabetes. It's recommended when there's a BMI of at least 35 and can be considered with lower BMIs of greater than 30 with concurrent metabolic disease, such as diabetes. The current available procedures include the sleeve gastrectomy, which is the most commonly performed today, Roux-en-Y gastric bypass, gastric banding, and biliopancreatic diversion. And finally, Plenity. This is an oral capsule that contains a super absorbent hydrogel. It's actually a pill that's taken with water before meals, 500 cc's or 500 milliliters. And since even though it's a pill, it's actually classified by the FDA as a device and not a medication. That has important implications because it can be used for lower body mass index values down to 25 instead of 27 or 30. The basic mechanism is that it fills up space so that one eats less. Compared to the pharmacotherapy, the weight loss benefits are not as great, but it is a potential option. So the take-home points as we conclude are that obesity and diabetes are diseases that affect millions of individuals in the United States, as well as cost billions of dollars a year. It's important to address these conditions together as they have many of the same other comorbid conditions and complications. Weight loss of even 5 to 10% can improve blood sugars, blood pressures, as well as cholesterol. Lifestyle modifications are the cornerstone of the treatment for both obesity and diabetes. In addition to diet and exercise, however, there are several pharmacologic treatments available and are indicated for the treatment of obesity that can also concurrently treat diabetes. I did want to highlight that World Diabetes Day is November 14th, and access to diabetes education is the theme this year. Additional resources regarding both diabetes and obesity can be found at these sites. So thank you.
Thank you, Dr. Stanback. That was an excellent presentation. I learned a little bit more than I already knew, but I appreciate it. I want to open it up to questions from those who have logged on this afternoon. If you do have a question, please use the Q&A box in the bottom of your screen and type in your question. I did have a question. I did have one question. As we enter into the holiday season, Dr. Stanback, what would your advice be for patients, your patients, whether they have diabetes or not, and how can they make healthy choices in the coming months or in a few weeks?
Yeah, that's a great question. And not one, it's one that I receive all the time. So I always recommend going into the holidays with a plan. So that you don't beat yourself up or get upset for eating something that was maybe outside of what your doctor told you to eat. So recognizing, okay, I may have dessert on Thanksgiving, but say I'm going to have just one slice of pie or one type of dessert. So always having a plan going into the day is important. Also, your plate size or portion sizes are important. One way of limiting the portion size is using a smaller plate so that if we think about on the holidays, we fill our plates up. If you use a smaller plate, you're more likely to have fewer calories on that plate. If you have a larger plate, making sure that you can see spaces in between the food can also be a visual cue to reduce the portion size.
Good, thank you. Thank you. So I will use my smaller plates to come with Thanksgiving. We have a question here. Why do people often regain their weight?
Yeah, so
they lose weight?
Unfortunately, the body puts up many mechanisms to guard against so-called starvation. And some of those can be alterations in certain hormones that actually increase hunger when we lose weight. And further, there can be other mechanisms that tell us that we need to just eat more when that's actually not the case. So it's actually sometimes our body works against us. And that's where we add on pharmacotherapy in order to target those specifically. Additionally, if we look at some of the other causes for obesity, there are other factors at play, sometimes psychological factors that need to be addressed, as well as other medications that can actually contribute to weight gain.
Perfect, thank you. Did anyone else have any other questions? I see someone has their hand up, but I would just ask if you could possibly use the question and answer button or the chat. That would be helpful. Another thing that I hear a lot about from people, whether or not they have diabetes or they need to lose weight, is the importance of water. So I wanted to just ask if you could just touch on the importance of water.
Yes, absolutely. So, water in general is what I recommend drinking and only drinking. Other beverages are sweetened, so juices, sodas, and I kind of have to clarify that sometimes. Orange juice is also juice. Cranberry juice is also juice. Ginger ale is also soda. So those have additional calories and carbohydrates that still go into our overall count for the day, but we often don't account for those. So drinking water is especially important, and also can help with satiety, actually.
Perfect. Another question is, what if it is, we're all busy, we all have lots going on. What if it is difficult to, what if exercise is physically difficult to, so what do you think? Like, what if having, exercise is just, physically difficult, especially if you are obese?
Yeah, so there are certainly limitations to physical activity that we are aware of. We know that there are complications associated with obesity, such as osteoarthritis, which limits our mobility in general. So sometimes it kind of becomes this cycle of, it's so painful for me to use my knees, but I'm being told that I need to lose weight in order for my knees to feel better. So what do I do? There are certain modifications, such as chair exercises, for example, wall exercises, upper body exercises that can always improve mobility. The main thing is being active. So even if you're sitting in a chair and you can move your upper extremities, or you can do leg raises. Also lower impact activities, especially during the summer. Swimming is a great lower impact activity, or water aerobics that can offload some of that burden.
Okay, thank you so much. I guess just going along the lines of how the holidays and drinking, and what would your recommendation be for someone who has diabetes about drinking a glass or two of alcohol?
Yeah, so it's something that has to be factored in, right? We did see during the pandemic, especially, increased alcohol intake, and that, as we see, there's also been increase in weight gain throughout the pandemic. So I've even had colleagues with their patients go through exercises of calculating the amount of calories in 2 glasses of wine, for instance, and that exactly matching up with that 20 pounds that they gained during the pandemic. So I would say limiting alcohol intake is certainly important, as there are additional calories in each glass of wine or your alcoholic choice of beverage.
Perfect. Thank you. Thank you so much. That's a great question. And thank you for the great answer as well. Were there any other questions for Dr. Stanback this afternoon? If not, I would also just like to, I would be remiss if I didn't mention at Suburban Hospital, we have the diabetes self-management training program for patients, for people living with diabetes. And so I just wanted to put a plug in for that. as well as for those who might not know, we have at Suburban Hospital, we have, health and wellness programs such as our senior shape classes for, it says senior in it, but anyone can take it because it's all over Zoom. And thank you again, Dr. Stanback, for being here this afternoon. And if there are any other questions, we will adjourn. Please keep your eye out for that link to the evaluation, and which I'll send out in a few minutes. And thank you again. And thank you again for your time, Dr. Stanback, and have a wonderful rest of your day. Bye,
Thank you
everyone.
very much.